So the strategic integration of traditional and complementary medicine into clinical practice guidelines. So this presentation has a slightly different perspective, I think, to the previous two, because it was about trying to integrate complementary medicine, traditional and complementary medicine, into the general clinical practice guidelines. So I have no conflicts of interest to declare, but I'd like to acknowledge Associate Professor Jennifer Hunter, who I worked with on this project. So just to start off with, the key objectives for clinical practice guidelines are to make recommendations and to inform decisions in clinical practice. So they're also an opportunity for integrating traditional and complementary medicine into sort of general healthcare. But they require modifying factors for meaningful inclusion. And the decision of these modifying factors needs to be systematic and transparent. And in our case, we used a scoping review to identify the modifying factors for the inclusion of traditional and complementary medicine before we did the systematic review of evidence of effectiveness. So just an overview of what clinical practice guidelines are. So they're consensus statements with recommendations for treatment. As you've heard from the previous two speakers, they make recommendations according to strength based on several factors. They aim to optimise patient care and support decision making, and also to inform policy. So they don't only standardise treatments, they can also inform decision makers or policy decision makers. They aim to compare benefits and harms of different treatments, and they're informed by systematic reviews of evidence, but they're also informed by the context or the setting of the treatment delivery. So they're systematically developed statements designed to assist decisions about appropriate healthcare for specific clinical circumstances, which means that they're more than just a summary of the evidence. So they include the quality of the evidence or the accuracy of the evidence, or confidence in the accuracy of the evidence effect. But also they include the adequacy of the evidence in the context of care. And that's what informs the recommendations, which can be either weak or strong, weak to strong. So there are limitations with just simply making recommendations based on an evidence hierarchy, and low quality evidence doesn't necessarily mean that a weak recommendation is made in a clinical practice guideline. This is only really one factor that's considered. So what are the contextual considerations? So firstly, there's clinical outcomes, so the relevance of the outcome measurement, the safety, the treatment effect magnitude. Then there's economic and cost considerations, whether the treatment's affordable to the patients and also to the health services. The logistics of the treatment, whether it's available and accessible and it's able to be implemented or else decommissioned. The clinical governance, whether there's quality can be assured, and also regulation over the delivery of the intervention. There is also contextual social considerations, so whether it's equitable and generalisable, the evidence is generalisable to the people that you're treating, whether there's a cultural context, so there's respect and diversity, can treat different culturally diverse people, and political and policy considerations, and also patient experiences and preferences, because people choosing to be treated are value-based decisions. So the recommendation in a clinical practice guideline is qualified according to these modifying factors. And these modifying factors can have an effect on the quality. They can have an effect on the recommendation that's independent to the quality, the grade of the quality of the evidence. So that means that you can upgrade low quality evidence to a stronger recommendation in certain contexts, and you can downgrade a high quality evidence to a weak recommendation in certain contexts. Okay, so some of these factors, which is a bit repetitive of the last slide, so patient preferences and values, according to policy, economics can influence these upgrading or downgrading of recommendations, the opportunity, logistics, the quality of the training and delivery of the service, and the generalizability of the evidence to a patient population or country group or cultural group or country. So just some examples. So you can have, these are examples when strong recommendations have been made despite the presence of low quality evidence. And this is according to the grade recommendations, grade directives. So when low quality evidence suggests a benefit in a life-threatening situation, when low quality evidence suggests a benefit and high quality evidence suggests a harm or a very high cost, when low quality evidence suggests equivalence of two alternatives, when high quality evidence suggests equivalence of two alternatives and low quality evidence suggests harm, and when high quality evidence suggests modest benefits and very low quality evidence suggests possibility of catastrophic harm. So these are the kind of contextual factors that can alter the strength of a recommendation. So just as an example of when, I'll give you two examples. So when low quality evidence suggests a benefit and high quality evidence suggests a harm or high costs. So for example, acupuncture for carpal tunnel syndrome, there's low quality evidence of efficacy for this, but compared to surgical management, which is high cost and potential operative risks, which has high quality evidence. So the recommendation in that situation was that there's a strong recommendation to first try the T&CM. So it's about sort of making the common sense decisions. And another example, so when low quality evidence suggests equivalence and high quality evidence suggests a harm for other options. So for example, acupuncture is equivalent to pharmaceutical medication for depression in teenagers, low quality evidence, but antidepressant medication increases the risk of suicide in teenagers, and that's high quality evidence. So the recommendation in this case is that there's a strong recommendation to first try traditional acupuncture before pharmaceuticals. So now just moving on to the second part of this presentation. So this is the contribution that we were invited to make for including traditional and complementary medicine into the guidelines for deciding palliative and end-of-life care for people with diabetes. So this guideline had been originally published in 2014, and the authors wanted to update the guideline and include some traditional and complementary medicine, because they knew that it had very high patient acceptability and that some of these therapies were actually being used in routine care. So they wanted to be able to inform evidence-based treatment by including traditional and complementary medicine into these guidelines. So I guess the first point about this is that we were invited to contribute to it. So, so I think because clinical practice guidelines, as you've noted with the previous two speakers, there's an element of consensus and collaboration and decision making that happens amongst interdisciplinary groups. I think that when traditional and complementary medicine is integrated into these guidelines, there needs to be some sort of relationship building in order for that to happen. So the objective of the guideline was to provide a framework for implementing diabetes, palliative and end-of-life care to support function and personalised proactive care planning. So it was focused on promoting personhood, dignity, autonomy and spirituality for people at the end of life who had diabetes. And the guideline was divided up into these 4 categories, which essentially represented the trajectory of palliative care for people with diabetes. So they could be in a functioning, well and independent state, and then have declining function with one or more comorbidities, including polypharmacy, that could affect cognitive function and their social isolation and increase carer burden. So you can see what the aims of treatments were in the right-hand columns. And then to a deteriorating further stage and then a terminal stage. So people at different phases have different needs in care. So we wanted to take a systematic approach to the PICO questions before we did the evidence review, because if you just rely on the people who are working, there's a bias or a prejudice towards the type of treatments that they use, and a cognitive bias with their own experiences. So we tried to workshop the essentially the problems that are important to patients in these different trajectory stages, the reasons people might use traditional and complementary medicine, and whether there was an unmet need or a gap in Western medical use. We also, for the intervention and control elements of the PICO questions, we wanted to find the interventions that are used for this patient group, the interventions that are provided by practitioners of traditional and complementary medicine, and also the interventions that are provided by health services, and the outcomes that people were looking for. So what are the outcomes that were important to patients, and what are the outcomes and the logistics and the governance that are important to health services? So they're the feasibility aspects of it. And we needed to do this because we didn't know which types of traditional and complementary medicines that people might want to use, and which ones were specifically useful in certain situations for this people in this who would use the guideline. So we started off doing a scoping review to inform the PICO questions, and then we've done and did an evidence review of up to 20 traditional and complementary medicine interventions. And we called this, in the scoping review, we called these contextual factors modifying factors. So basically we were looking for traditional and complementary medicines that were often used, commonly provided, routinely provided in palliative healthcare services, that address comorbidities, especially when conventional care is ineffective, costly, or there's low patient acceptability, that simultaneously address multiple problems for traditional and complementary medicines with high quality scientific evidence about effectiveness or ineffectiveness, high quality evidence about risks or safety, and logistically feasible in the Australian healthcare setting. And these are the results of the scoping review. And so you can see that we included 80 studies in the narrative synthesis. And for the modifying factors, for the papers on modifying factors, we graded them between 1 to 5, and we only included those that were grade 4 to 5, so higher levels. And for risks, we included 8 papers, and for the evidence of effectiveness, we included 23 papers. So this is just a summary of how we graded the papers relating to the modifying factors. So they were essentially graded according to the relevance of the paper to the clinical practice guideline. Thanks. So we found that the utilisation of traditional and complementary medicine in Australia by adults with diabetes was about 37%, and at the end of life about 25%. Most people were using these medicines alongside conventional care to support general health, symptom relief, improved functioning and quality of life, and for psycho-spiritual well-being and self-efficacy. The most commonly used traditional and complementary medicines were nutritional supplements containing nutrients and herbs, Western herbal medicine, Chinese herbal medicine, and less than 10% were consulting a practitioner. We found that traditional and complementary medicine is likely to provide benefit for these conditions listed on the left-hand side of this slide, but it's unlikely to provide benefit for the conditions on the right-hand slide. So the intervention shortlist, which included scientific evidence of effectiveness or non-effectiveness. So we included acupuncture for common palliative care symptoms, so individual symptoms or clusters of symptoms, acupressure wristbands, vitamin B12 for diabetic peripheral neuropathy, neuropathic pain, massage for pain, aromatherapy and massage and music therapy, and meditation, mindfulness for psycho-spiritual well-being, stress and relaxation. We found that there was evidence of possible positive effectiveness for Chinese herbal medicine for peripheral neuropathy, some single herbal medicines for fatigue, pain, depression, anxiety, wound healing, naturopathy for improved well-being, self-efficacy and mood, Tai Chi for prevention of falls and frailty, aerobic exercise for quality of life, alpha-lipoic acid for pain, etc., yoga, therapeutic touch, and some nutritional supplements, zinc, omega-3 and vitamin D3, and ginseng for fatigue. So we were also able to provide some expert safety information. So we were able to specify the safety of herbal medicines in conjunction with the pharmaceuticals that will be used in that clinical context. And to clarify, we clarified that clinicians should consider potential benefits before advising people to cease using a traditional and complementary medicine. And we were also able to assess the logistical feasibility in Australia of delivering traditional and complementary medicine to these people with diabetes at the end of life. And this is a photo of the actual guideline with the appendix, the complementary medicine in it. We were able to say when a traditional and complementary medicine should be started. So acupuncture should be used for pain, fatigue, mental health, and to improve quality of life, Tai Chi and naturopathy. For patient preferences, acupuncture wristband, and meditation, mindfulness, and when the intervention is logistically feasible, so vitamin B12 for that. We were also able to articulate the high value of traditional and complementary medicine that people with diabetes at the end of life value traditional and complementary medicine. And here's just some of the other recommendations that we put in. So with glucosamine, we were able to upgrade the recommendation that was intended. And for omega-3, we upgraded it as a patient-valued outcome measure, and some of the other supplements, which I won't go into in too much detail. It's running out of time. Thank you. So